Hi everyone, I'm delighted to be here today with Dr. Emma Turner. Em is a fellow Colgate advocate for oral health and has spent the last 3 years of her career working in tertiary hospitals, first in Melbourne and now in the Northern Territory. Today, Em and I will be discussing some key strategies to remember when managing patients presenting with dental trauma.
Thanks for having me, CJ. Our chat today is by no means all-encompassing, but hopefully will provide some points for reflection to guide you to some useful resources in managing the 1 in 3 of us who's had some sort of dental injury.
So, Em, a patient walks into your clinic with a dental injury. Could you tell me what kinds of questions you might ask them at the onset?
Absolutely. So in a clinical setting, you might already have some of this information from the screening questions that your receptionist asks when a patient self-refers over the phone. And I gather a lot of this data from the ED team that calls me, but it's important to take a really good history. So first of all, who is the patient? How old are they? That information gives you a bit of a clue in terms of whether it's likely to be a primary or a permanent tooth involved, and if it is a permanent tooth, what stage of root development you can expect. It also tells you a bit about what you can expect from patient cooperation. So is it going to be an LA case or a GA case? And will the patient tolerate ongoing care? And that'll dictate your management. So if you put a wire splint in a 2-year-old, for instance, under GA, will you be able to polish off all the composite in the chair afterwards? I'd say probably not. So is the patient otherwise well? You need to take a really good medical history in managing any kind of patient with trauma. And are their immunisations up to date? So we want to know, for instance, about their tetanus status in case they've collided with a rusty playground or a tooth's been cast into the sandpit. Then, of course, you want to know what happened. So what was the mechanism of the injury? When did the incident occur? Was there a loss of consciousness and how long for? And are we suspicious that there might be other concomitant injuries, like a broken arm if a patient's broken their fall or thrown some punches, or, for instance, double vision or trismus might be suspicious of other facial fractures. Obviously, isolated dental injuries are well within the scope of private practice or community dentistry, and generally patients who've had big falls will present to the hospital first anyway, but if there is anything else going on, patients might benefit from medical review, at which point their teeth can wait. But for instance as well, like if a patient has a lip laceration crossing the vermilion border, they might also benefit for plastics input unless you're a very confident suturer. So next up, have all the tooth fragments been accounted for? And this is where your radiographs come in handy later. If not, because we might find that there are bits of tooth in the soft tissues, or a tooth that we think has come out clean has actually been intruded completely or fractured and partially retained. We also need to work out whether there's an implication for oral function. So, for instance, are there any occlusal interferences? Has the patient tried to eat anything since? So, for instance, if you have a 3-year-old that's happily chowing down on some sandwiches in the waiting room, they're probably okay. But if they come to you on day 3 post-injury and they've lost 10% of their body weight because they can't feed orally, then that's another story.
Absolutely. There's a lot of things to consider, isn't there? So, in your experience, what are some of the most frequent causes of dentoalveolar injuries?
Yeah, so we tend to see a bit of a breakdown by demographic. In the Lilies, dentoalveolar trauma presentations are mainly in kids having Humpty Dumpty moments, so falling over at home or in the playground, whereas in school-age children, it's generally more related to sporting injuries and kids taking tumbles off bikes. But I always take this as an opportunity to congratulate parents in keeping their kids active and away from screens. And then in the 20-somethings and above, most of what I see at least relates to a pattern of alcohol-fueled incidents or occasional occupational injuries, and then of course falls in elderly patients. We've also been seeing a lot of collateral from the rise of e-scooters, and then of course every once in a while we see something a little bit more left of field, like a face versus angle grinder.
Oh my goodness, that doesn't sound good at all. Look, I guess touching on sports, that's always why we recommend mouthguards to be worn during contact sports, really to help reduce the occurrence of sports-related dental traumas. And what would you say are some of the most common dental injuries?
Well, broadly speaking, dentoalveolar injuries can be classified in terms of either luxation injuries, where the tooth's displaced from premorbid positions, or more dramatically, avulsions, where teeth make their way out of the socket altogether, or fractures to the teeth and supporting structures, which can occur at a number of levels, including enamel, dentine, pulp, root structure, or the alveolus itself. And then, of course, there are associated soft tissue lacerations or degloving injuries that accompany the hard tissue injuries. But often we see combination injuries in more complex presentations that we get at the hospital, so I see quite a nice mix. But there is a WA paper that we'll link below that kind of says that uncomplicated crown fractures are the most common injury that you're likely to see in general practice.
Yeah, I can imagine a lot of this would be often very confronting for both the patient and the clinician when presenting to a dental clinic. So what is most critical when a person has suffered an injury?
Well, basically, working as tooth ED at the hospital, I developed a sense of kind of zen and composure in managing trauma cases, because we see it all the time and follow such a systematic workflow. So it's just a process of putting all the pieces of the puzzle back together. Being sent photos in advance really allows for that sense of serenity, because you can sit there with a picture of the patient's injury and think, okay, what are we looking at? And just take a moment to kind of reflect and have those IADT guidelines there as a point of reference. But no, sometimes it's easier said than done to keep your cool if you're thrown into an emergency case in person where there's a patient that's also shaken by having sustained the injury. Honestly though, the thing that I would say is most critical isn't the teeth, but providing the patient, and sometimes surprisingly more importantly their family, with reassurance that everything's going to be okay and can be managed, and if not, just stepping them through the options that are available to them should the emergency management fail in the short to medium term, or if their teeth had vanished at the site. Of course, it can feel like information overload sometimes, but it's all about reading the situation, giving a patient little nuggets of information that make them feel at ease, that they're going to be able to smile again. And of course, beyond that, from the perspective of acuity, obviously avulsion is a time-sensitive injury to manage, so obviously that's a critical thing to recognise. But unfortunately, by the time we see most of our patients, the avulsed teeth have been outside of the mouth for an extended period, at which point you just need to explain to the patient that the next step is timely initiation of root canal treatment to keep them in situ disease free.
Yeah, absolutely. And I guess, storing these knocked out teeth in adult teeth in milk or saliva is often described as the best solution to help preserve a tooth for reimplantation.
Yeah, so it's best if you can pick up the avulsed tooth by the crown, gently rinse it and replant it immediately, but milk's generally considered to be the best storage medium because it's widely accessible if patients can't bear the thought of immediate order replantation. Adrenaline usually works wonders for pain relief at the time, but it's easier procedurally to get the tooth back in before there's an established blood clot in the socket, but obviously when they present to us we can manage it from there if need be.
Yeah, and so that's for adult teeth, but baby teeth that are knocked out before they're ready to naturally fall out should not be reimplanted in the mouth to prevent possible infection and damage to the underlying adult teeth.
Yeah, that's exactly right. So most of our approaches to managing trauma in the primary dentition are pretty conservative unless there's a disturbance to bub's bite resulting in a traumatic occlusion that will interfere with them eating.
Yeah. So what else is usually done if teeth have been knocked out or displaced due to trauma?
Well, here's where I would refer to the IDT guidelines for more systematic kind of procedural guidance that we'll link below here. But broadly, in terms of practical guidance, after you've taken a comprehensive history that we were kind of talking about before and done a radiographic and clinical assessment. So in the primary dentition, as I've just alluded to, we only really intervene if a tooth or dentoalveolar segment's interfering with the bite or is excessively mobile. So that's either just a quick kind of digital reduction if the tooth's firmly in but the apex is trapped in a dentoalveolar fracture, or extraction of the extruded or laterally luxated teeth if they're terminally mobile. Then, for the permanent teeth, under profound local anaesthetic, we flush out the clot if the tooth's been avulsed to debride the blood clot. We reposition the teeth with appropriate radiographic guidance and feedback from the patient in terms of occlusion and aesthetics. And that's where I find that pre-injury photos actually really help. Like, did they have a premorbid diastema or did they have crowding? What are we working towards? I usually find that if you get them to close, it's also a big help because it can squeeze them into a comfortable occlusion, and that saves you a hand as well when you're working. And then after that repositioning step, we splint them, which usually involves 2 sound teeth on either side of the teeth that sustain the injury, and that can be tricky in the mixed dentition, but we want to seat them with really nice firm pressure in that splint. And the splint usually stays there 2 to 4 weeks. So I generally warn the patient that they're going to have pseudo braces for that time and to steer clear of the minties and carrots that might debond the splint. And then thereafter, they'll come back for clinical review, pulp testing and splint removal, at which time I hand them over to close follow-up with the care of their local general dentist or endodontist, with a nice little letter and consideration of root canal treatment as indicated. So this is something that I really take the time to impress upon our patients, because otherwise they come back to ED with the sequelae of pulp necrosis. And I guess I'm quite lucky on this front in that most of my emergencies pop up after hours and at the end of the day or on weekends. So I've got time to manage the emergency without the pressures of a full day with other patients to accommodate. And I really enjoy taking that time to chat to the patients, to kind of step them through their likely clinical trajectory in the days, weeks, months, years after the injury, and to consider the tangible implications of being lost to follow-up. So swelling of the lip, draining sinus, delayed pain arising after the initial injury heals, so that the patients know what to look out for.
Yeah, I mean, unfortunately, that's always a risk for traumatised teeth, isn't it? And after a tooth is reimplanted or repositioned, a soft diet for at least 3 weeks is recommended to reduce excessive loading on the tooth, and gentle brushing of the area is advised to keep the tooth clean. Sometimes an antibacterial mouthwash may be recommended for short-term use to help keep the area clean whilst the area is healing.
Yeah, absolutely. Us replanting or repositioning the tooth is only the beginning of the journey, and aftercare really is key here. So yeah, pivoting a little, I feel like, and this is particularly important for crown fractures actually, because most people kind of think they're one and done once a filling's been placed. But unfortunately, pulps can be notoriously unpredictable, and I see so many patients coming in for dental workups whom I notice have an incidental periapical radiolucency, especially in their maxillary interior teeth, that's either gone unnoticed because of a loss to follow-up in asymptomatic patients who don't self-present, or has been symptomatically missed because general dentists kind of follow the cookie cutter protocol of taking bite wings for every patient, and it's not necessarily routine to take that anterior periapical. So it's our professional responsibility to follow up these injuries and also to have an index of suspicion in new patients presenting with discoloured front teeth or a known history of trauma, to keep our patients out of pain and the ED, I guess.
Yeah, absolutely. Well, thank you so much, Emma, for chatting with us today and providing us with the key strategies to remember when managing patients with a history of dental alveolar trauma. So we'll see you again next time. Thanks
Thanks, CJ.